Hello everyone, welcome back. My name is Dr. Vijay Bhatia. I work as a psychiatrist and have experience of working in mental health for the last 30 years. Today we are going to discuss about dissociative disorders. I am showing this picture here to just show that one of the dissociative disorder is multiple personality. So one person here can be a child at some point, a female, a young female, an old person, or old lady, or crazy lady. So there can be multiple personalities of one person, and they switch from one to the other quite quickly as well, and without any warning, and for that period they behave in that way. We will discuss this in more detail for individual ones, but that is what the dissociation is, when you have changed your identity and you're not aware of certain of the part of the true identity or other things. Okay, so dissociative disorder. The common theme that are shared by dissociative or conversion disorders are partial or complete loss of the normal integration between memories of the past. So in the photo we seen, or the picture we seen, the person who is behaving as a young child or teenager, and then he is behaving as an old person. This old person has no memories of this personality. And even in other, this is just an example of multiple personality, but even in dissociative states, the person will lose some kind of memories, and either it is partial or it is complete loss of the normal integration between the memories of the past. And as we talked, there is loss of awareness of identity. As we said, the person is behaving as a young person, and later on as old person, and later on as a female. So the same person is not aware of their identity. They changes, they switch. And immediate sensations. So there is loss of integration between memories and even immediate sensations. Immediate sensations means even things like they feel different, they sense different, they perceive differently, they make different meanings to the same sensations, and they're different for each person. So if this person is loving toys, this person might hate toys. This person is loving Mr. X, this person might hate Mr. X. So the sensations, the feelings of love and feelings of touch, feelings of others, they change as well. And there is loss of the normal integration between memories of the past and also control of bodily movements. So the young person may not be able to walk very fast, and the adult person may be able to even run, and the old person may even walk even more slowly or even some limp. So all these dissociations can happen at the same time in a person, and then they behave differently as a different individual, as if they are a different person in a different place and different relationships. So any of these symptoms can happen. Dissociative disorders, in fact all types, tend to remit after a few weeks. So they last for about a few weeks or sometimes for few months, particularly if their onset is associated with a traumatic life event. Now, this is a psychological trauma, and this is very personal to the person. And for different people, this trauma can be of different significance. It might sound trivial to one person, but to the other person who is affected, it can be a major setback, mental stress, too much to cope with. More chronic disorders, particularly like paralysis, somebody can't walk, they can't move their arm or hand or finger, or they can't speak, or there is a partial paralysis of the whole one side of the body, or both the legs, or normally just one leg or one arm. So there can be paralysis, complete loss of the muscle movement, voluntary muscle movement, or anesthesia when you can't sense anything. There is loss of touch or loss of pain or loss of sensation in one form or the other, in certain part of the body or in half of the body, and sometimes the whole body. May develop if the onset is associated with insoluble problems, where the problems are there but they cannot be solved by that individual, or he cannot find the solution. He feels trapped in that, and it can happen in interpersonal difficulties when husband and wife or partner, boyfriend and girlfriend, they have certain issues between them. They are quite severe and quite to the extent they can't live without them, they can't live with them, and they don't have any solution. So they are in a very difficult situation, and both ways they are losers, and they then start having different dissociative symptoms. And psychologically, there might be that they are thinking that they will get more attention or some kind of focus or something, but that is difficult to prove, and it is normally not even proven many times. They just behave in that way, or loses the loss of muscles, sensations or movements in one part or the other. And sometimes person can say, I can't even walk, especially in front of the partner. But when the partner is not there, you might see they might be able to go to the toilet themselves, although very slowly. These disorders have previously been classified as various types of conversion hysteria, because it used to happen more in women of middle class and in certain groups as well. And the person will behave in that way. They are presumed to be psychogenic in origin because of the traumatic event. In some we can identify this traumatic event, but in others we can't able to find what was the trauma, what was the damage done psychologically to that person. Either they can be trivial for other person, but for the person it is quite serious to them, being associated closely in time with traumatic event. So what we believe is there has been some kind of traumatic event which is psychogenic in origin, and these symptoms, either loss of muscle tone or loss of movement or can't even walk, this develops and they are in close relationship with the traumatic event, or sometimes to insoluble or intolerable problems where they feel that way, that they cannot resolve the issues by themselves, and they don't know how to get out of the situation, and they feel trapped, and they develop some of these symptoms, which they believe might help them, but we normally don't know whether that is their intention. What we see is a symptom, a person there who has lost a part of the limb, or they can't move their limb at all. And if you explore that, and this keeps on happening for the days and days, and sometimes few weeks, and even sometimes some months, depending on the severity of the psychogenic trauma. The symptoms often represent the patient's concept of how a physical illness would be manifest. So the person has some idea that if a person is having a paralysis, they can't move their leg, or they might have seen in their during their development, their grandfather or somebody suffered with a paralysis and they couldn't move their arm and leg, or just arm, or they lost certain sensations in certain parts of the body. And this patient who has developed a dissociative disorder, they believe that they are behaving in that way, as if they can't walk because of the paralysis of the leg. And medical examination and investigations do not reveal the presence of any known physical or neurological disorder. So what we are saying is that this person has believed that a paralyzed person will act and behave in that way, and he will represent with the loss of either walking or talking or seeing or moving their arms. And they believe that, but when the medical examination is done and neurological examination is done, the medical team do not identify any underlying organic cause for that disorder to be present. So in a way, we can say, could it be the person faking it? And they may not be faking, in terms of they may not have that intention to fake it in the real sense, but subconsciously they may be faking it, and they are not even aware of that if they are faking it. So in addition, there is evidence that the loss of function is an expression of an emotional conflict or needs. So if you try to explore the situation, if you meet the other family members or the wife or the partner and explore the symptoms, and then you realize that there has been conflict going on, either separation or some kind of trauma has been happening, or somebody has lost in the family, there is bereavement of somebody. So there is some kind of emotional conflict or need which is contributing towards these things. But it is hard to actually relate these together. The symptoms may develop in close relationship to psychological stress and often appear suddenly. So they present quite suddenly to the accident and emergency department with loss of sensation for the pain, or loss of muscle movement in certain areas, or they can't move their arm and leg suddenly. So they appear quite suddenly, and the medical team does not find anything, but they do identify that there might be some kind of psychological trauma. Only disorders of physical functions, normally under voluntary control, and loss of sensations are included here in this category. But there are other dissociative disorders where the number of other, even involuntary muscles and involuntary control can be affected. Disorders involving pain and other complex physical sensations. So here we are talking about pain and other physical sensations, mediated by the autonomic nervous system. Autonomic nervous system is the nervous system that supplies to the heart, to the lungs, to the kidneys, and blood vessels. So they are affected as well, are classified under somatization disorder because they are not under voluntary control, they are autonomic control, and they are not included in dissociative disorders. Only the disorders which has voluntary control are involved in the dissociative disorders. The possibility of the later appearance of serious physical or psychiatric disorders should always be kept in mind. Dissociative disorders are also sometimes known as conversion hysteria or conversion reaction, or just an hysteria in general terms, or hysterical psychosis in terms. As we talked about earlier, malingering, that means false, fake, faking, should be excluded. The person should not have the intention to fake these symptoms. Especially there is no conscious simulation to cause the paralysis of the leg or arm. There is no conscious simulation, although we believe there is subconscious processes going on. The particular type of dissociative disorders we are going to talk about is dissociative amnesia. Amnesia by definition is loss of memory. The main feature is loss of memory, usually of important recent events. That is not due to organic mental disorder. That means the person is not suffering from dementia or epilepsy and is too great to be explained by ordinary forgetfulness or fatigue. So the person will simply say, I don't know my address, I don't know my name, and that is so severe for any person to forget these things or forget where they come from. So this type of amnesia, when you hear, then you start thinking, what is the person trying to say? He can't even remember his name. He doesn't know where he come from. What is his father's name? What town did he was born? So I mean, things like that, you will start thinking, no, this is something dissociative amnesia. It can't be true, because that is too much for any, even people with dementia don't forget that kind of stuff. Amnesia is usually centered on traumatic events, such as accidents or unexpected bereavements, and is usually partial and selective. So that is another important feature, that when you actually try to explore the loss of memory, and then you will try to understand that they are centered around these traumatic events or accidents or unexpected bereavements. Complete and generalized amnesia is rare and is usually part of a fugue. Fugue is another part which we are going to talk in the next slide. If this is the case, the disorder should be classified as dissociative fugue. The diagnosis should not be made in the presence of organic brain disorder, as we said, like dementia or epilepsy, and people with intoxication, like with taking alcohol or benzodiazepines, or even sometimes excessive fatigue can cause some kind of forgetfulness, but not to that level. The other one is dissociative fugue. In dissociative fugue, we have all the features that are presented in dissociative amnesia as above, plus there is a purposeful travel beyond the usual everyday range. So the person would have traveled to another town, to another city, to meet a family, to meet a friend, and they are not aware how did they come, where did they come from. So the amnesia, all the loss of memory is there, but they are traveling, and the person who see them, they apparently can't find any difference between normal person and the person with the dissociative fugue. Although there is amnesia for the period of the fugue, the patient's behavior during this time may appear completely normal to any independent observer. What is dissociative stupor? Stupor is diagnosed on the basis of a profound diminution or absence of voluntary movement. So what happens, there is voluntary movement is lost, either in the speech and normal responsiveness to external stimuli, such as light, noise, touch, but examination and investigation reveal no evidence of a physical cause. So the person will come to the A&E brought in, he is completely paralyzed. They can't move their leg, their arm, or they are not opening their eyes, they are not talking. They are just as if they had some kind of paralysis of the whole body, and even if you touch them, if you sometimes even pinch their muscles, they are not responding at all, mostly to the light touch and noise, and they are not. But if you examine with a like a knee jerk with a hammer testing, the reflexes will be present and the planters will be normal. And if you open their eyes, there is some kind of eye movements are coordinated, normal muscle, and if you examine their muscle tone, they will be normal, but the person is saying I can't move their leg or arm. And even if you look at their static posture and the way they are breathing, it often looks that they are well maintained. And often when you open their eyes and ask them to look or move your finger to the left and right and see, mostly they are coordinated. In addition, there is positive evidence of psychogenic causation in the form of recent stressful events or problems. So if you look at the causation of this or ask the family members what else is going on in the family, they will explain, or somebody has died, there is separation, or person is separated from the relationship, or some acute serious thing has happened, or insoluble problems have happened within the circumstances of the family. What is trance and possession disorders? Trance disorders in which there is a temporary loss of the sense of personal identity and full awareness of the surrounding. So here we are trying to separate these two. In the complete dissociative disorders, there is a loss of identity and there is loss of awareness of the surrounding. But in the trance and possession disorders, here there is only the temporary loss of the sense of personal identity, whereas there is full awareness of the surroundings. They know where they are. They know what town, what place, what gathering they are in present at that moment. However, they don't know who they are. Ask them, what is your name? Are you male, female? They give wrong answers, or they don't know. They tell different answers. So there is, and it is temporary, and include here and only trance states that are involuntary or unwanted, occurring outside the religious or culturally accepted situations. What does it mean if you are in a religious ceremony where you are in a gathering or surrounding and the saint comes and you lose your identity, you are part of the group, and so you should not be diagnosing these in those cultural accepted situations. You should diagnose this only in places when the person, there is no relation with the surrounding and it does not fit into their religious or cultural background, and they have there are involuntary or unwanted occurrings. Okay. Dissociative motor disorders. We already touched on this. It is the commonest varieties. There is loss of ability to move the whole or part of a limb or limbs. So it might be just one leg or both legs, one arm or both arms, or one leg and one arm, or only one side. There may be close resemblance to almost any variety of ataxia, apraxia, akinesia, aphonia, dysarthria, dyskinesia, seizures, or paralysis. And this involves psychogenic aphonia or dysphonia. We will talk about individual of every one of these. So in the next slide, so ataxia. What is ataxia? This is a neurological sign consisting of lack of voluntary coordination of muscle movements. That can include gait abnormalities. So if you ask the person to walk on a straight line, they won't be able to walk in a straight line. Speech changes. There will be some changes in the speech. They will have difficulty in pronunciation in certain words or saying certain words, and abnormalities in the eye movement. So there might be some kind of double vision, or when you ask them to look on one side, the eye movements may be slightly abnormal in one way or the other. What is apraxia? Apraxia is characterized by loss of the ability to execute or carry out learned purposeful movements. So if the person knows how to comb their hair And if you tell them, take this comb and show me how will you comb your hair, they will not be able to do it. There is some kind of coordination difficulty, although they understand it clearly what they have to do, but they actually can't execute that activity, purposeful movement. What is hypokinesia? Hypokinesia is the decreased bodily movements. So the muscles of the arm or the leg, they decrease in their movement. If you ask the person to walk, they are walking very slowly, very gradually. What is aphonia? It is defined as the inability to produce voiced sounds. So if you ask the person to say my name, they will have difficulty. What is dysarthria? Dysarthria, this means not straight, having some problems with it. Arthria with the joints is a condition in which problems effectively occur when the muscles that produce speech, often making it very difficult to pronounce words, so they will have difficulty in pronouncing words, and this is because of some problems in the muscles that supply their jaw or the tongue. Dyskinesia. This means again some kind of disorder, not right, and kinesia is to do with the sensation, with the movements. Refers to a category of movement disorders that are characterized by involuntary muscle movements. Remember, this is involuntary muscle movements, the muscles that supply the speech, like the heart and intestines, other muscles, they are involuntary muscles, including movements similar to tics or chorea. So they can have tics, they can have vocal tics, or they can have motor tics. They might just stick their tongue out or blink their eye or something, or even chorea, that the movements of the arms is like a discoordinated in jerks and small fits and stops and goes. Are diminished involuntary movements. So even the voluntary muscles are diminished. Dyskinesia can be anything from a slight tremor of the hands to an uncontrollable movement of the upper body or lower extremities. So they can literally start shaking the whole body, lying down on the floor as if they have no control over it. So that is a dissociative motor symptom, and that particular one will be like dyskinesia. Dissociative convulsions, and the other one we've seen that the person is just moving on their whole body or the arm or the leg. Dissociative convulsions may mimic epileptic seizures. It sounds that as if the person is actually having epileptic seizure, with all the features that muscles are going into a fit with contractions or tonic and clonic or complete into state. However, if you look into these things, the differences between dissociative convulsion and true epilepsy is that in true epilepsy people will bite their tongue because they have no control when their jaw muscles contract in such a way that they have no control, and in the process they might bite the tongue, and tongue might be bleeding, and sometimes lip is held in between the teeth, and because in true epilepsy the person will fall, and if the person fall they might get a bruise or something, but in dissociative convulsion, even if they fall, they will fall very gently so that they don't get any bruise and don't break anything. And normally in true epilepsy, the person might be incontinent of urine because they have lost the control. All the body muscles are contracting, relaxing, and contracting in a regular fashion, and they have no control. And bladder muscles will contract as well, and they might urinate themselves and wet themselves. But in dissociative convulsion, that doesn't happen. And again, with true epilepsy convulsions, there is normally a loss of consciousness. especially if it is a tonic-clonic generalized convulsions. Uh, However, in dissociative convulsions, either the consciousness is maintained, or if not, it is slightly replaced by a state of stupor, as if they are lying down in trance, as if they are lying down in a calm fashion. So there is some dissociation between the true symptoms and the false symptoms. We don't know the exact causes, however, we believe that it is due to the underlying psychological trauma or stress that might have contributed towards. They look like true illnesses, like true paralysis, like true convulsions, like true forgetfulness, like true dementia, but they are not nothing like the true thing. When they are tested physically with investigations or with other things, so they do not represent the true picture of the illness. However, we can't even say that this person is malingering, is faking this for gain of something or attention of something. So that's why these are called dissociative disorders. Dissociative anesthesia and sensory loss. Anesthetic areas of skin often have boundaries that make it clear that they are associated with the patient's idea about bodily functions rather than medical knowledge. So the person will come, they will say, oh, I can't feel anything in this part of my arm below the elbow. And this has happened since yesterday or a few days ago, and I've tried everything. There is no feeling at all. But they do not know when it is medically tested, it does not fit the criteria the way it should be in the true illness or the true nerve damage. There may be differential loss between the sensory modalities which cannot be due to neurological lesion. Sensory loss may be accompanied by complaints of paresthesia. Paresthesias are abnormal sensations like pins and needles, tingling sensations in the hands and fingers and toes. There is loss of vision, and the person will simply say, I cannot see with my left eye or right eye or both eyes, and they might complain that hearing is gone, I cannot hear anything. And they can happen in dissociative disorders, although they are very rare. So the person is trying to show that it is a real loss of hearing. However, when the tests are done, they are nowhere near the actual deafness. And this will include the psychogenic deafness. So in this one, there is anesthesia or sensory loss, some kind of hearing or vision. Other disorders in the dissociative disorders, there's some others, but the important one I want to talk about is one is the cancer syndrome. Multiple personality, we already mentioned in the beginning some of them, and the twilight state. The twilight means when the sun is downing, the sun is gone off the horizon, and early morning before the sunrise. At that time, the person will feel very different. However, let's talk about a little about cancer syndrome, because that has come few times. Cancer syndrome is a rare dissociative disorder characterized by nonsensical and wrong answers to questions. You ask them any question, they will give you some answer which is totally wrong. And other dissociative symptoms such as fugue, amnesia, or conversion disorder, often with visual pseudo hallucinations. The true hallucinations will look like true perceptions, but in pseudo hallucinations, it could be just in their head, or they could be just partial, or they are just slight noises or slight uh, 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 changes in the perception of the hallucinations, and there might be object present there, stimulus present there, and it may not be present there. Often with visual hallucinations and a decreased state of consciousness. So the main feature is they will give you the nonsensical and wrong answers. The syndrome has also been called nonsense syndrome, Balderdash syndrome, syndrome of approximate answers. So that is another one. So whatever you ask, where have you come from? I have come from, they will just say the nearby town. How are you? You are okay. And so they will not say I am okay, they will say you are okay. So they have this approximate answers, or sometimes completely nonsensical answers, and it sounds that as if they are like having they are called hysterical pseudo dementia, or sometimes prison psychosis, because it is quite common in prisoners. The term prison psychosis is sometimes used because the syndrome occurs most frequently in prison inmates, where it may be seen as an attempt to gain leniency from prison or court officials. Psychological symptoms generally resemble the patient's sense of mental illness rather than any recognized category. So they will pretend as if they are suffering from mental illness, whatever their perception of the mental illness is, rather than any real syndrome or disorder of the mental disorder. The syndrome may occur in persons with mental disorders such as schizophrenia, depressive disorder, toxic states, paralyses, with loss of the tone of the muscles, and alcohol use disorders and factitious disorders. Cancer syndrome can sometimes be diagnosed as merely malingering, but it is more often defined as dissociative disorder. Thanks for watching. Press the like button if you like this video, share with your friends, and please subscribe the channel for more videos on the mental disorders and their symptoms. I see you again.